So this is pharmacology and we are talking about pharmacokinetics. Pharmacokinetics, from the word kinetics, it's talking about movement, kinetic energy. So when we are talking about pharmacokinetics, when you take a drug, you are looking at all the steps that the drug is going to take to move from the site of administration until it has gone to the target tissue. Say I've got a headache. I'm going to take an oral drug. That drug is going to go in the GIT. From the GIT, the first thing that is going to happen is that it is going to be absorbed. So the first step of pharmacokinetics is absorption. When that drug is absorbed, the next thing that happens is that that drug has to be distributed. To be distributed means it now goes to the actual tissue where it's supposed to be taken. For example, I'm having a headache, more likely maybe because the blood vessels of my head are constricted, so there's not enough blood supply there. So maybe that drug is a vasodilator, so it will go to the brain via blood. So that is distribution. And then, if you want to stop the work of a drug, you can break down the drug. That's metabolism. Now, metabolism can also happen for drugs that are taken and they are inactive to activate them. So, when the drug has finished doing the function in the body, it is going to be removed from the body either by the liver, the kidney, the lungs, and that is elimination. So these are the four steps or the four processes of pharmacokinetics, abbreviated as ADME, ADME: absorption, distribution, and metabolism and elimination. So pharmacokinetics, we describe it as what the body does to the drug. Body to the drug. We have got pharmacodynamics, which describes what the drug does to the body. But this is what the body does to the drug. The body is going to absorb the drug, distribute the drug, break down the drug, and then remove the drug. So the first step or the first process in pharmacokinetics is absorption. Drug absorption is the movement of the drug that you've taken from the site of administration into the bloodstream. For example, there are some drugs that are going to be taken by mouth. Those are oral drugs. So from the GIT, they are going to be absorbed. Some drugs are injected directly into the vein, so the absorption is direct because you are going to inject them into the veins. They are already in the bloodstream. So given by any route other than IV, drug molecules must cross tissue membranes. IV is the intravenous route where you are injecting the drug directly into the veins. So given by any other route other than direct ingesting in the vein, whether by, for example, if someone has got asthma, drugs that are given to asthmatic patients, you want them to be restricted to the respiratory system. Or let's say those topical drugs like creams, drugs that are put in creams, you are going to apply it on the skin and then it will now be penetrating the skin to enter the blood. So any method or any route of drug administration other than through the IV, the drug has to pass through a membrane. It has to cross the epithelium or the subcutaneous tissue or the gut endothelium or the capillary wall to be able to enter the blood. And drugs are going to be transported across biological membrane by different mechanisms. Okay, remember you've taken the drug and then it has to pass through the epithelium. So some of the drugs can pass through via passive diffusion, others by filtration, others by facilitated diffusion, others by active transport, and some others by endocytosis. These are methods by which you are going to be able to take the drug, absorb the drug. So when we are talking about absorption, you can describe absorption in terms of numbers, and we use a term which we call bioavailability. So what is bioavailability? Bioavailability is defined as a fraction. Please take note of the word fraction because it is in comparison with the actual. So a fraction of the drug reaching systemic circulation after a particular route. So let's say, for example, I got 100 milligrams of a drug and then I gave you to take by mouth. Of that 100 milligrams of the drug, only say 20 milligrams of that drug is actually reached the body where it is supposed to go. That is the bioavailability. So bioavailability is going to be that 20 out of the 100 that I gave. So it is a fraction of the drug that is reaching systemic circulation after a particular route. It's actually a measure of how much of the drug reaches systemic circulation to produce an effect. So meaning that for drugs that have got a low bioavailability, more likely you're supposed to they are not reaching well the place where they're supposed to reach because majority of the drug is actually being lost in the process. Okay, so it is only the intravenous route that has got 100% bioavailability. Why is that? Because if I inject a drug in the blood vessel, it is direct, it's already in the blood vessel. And we are saying bioavailability is a fraction that is reaching systemic circulation. Systemic circulation means that the drug reaches the blood. So if a drug is already in the blood, that is already bioavailability. So IV route has got 100% bioavailability. Is that a question? Are we moving together? Okay. So when you look at this curve that is here, this curve is telling us of the concentration against time. You can see at the beginning when time is zero, when you inject, like when you give a drug to someone. So here we have got two routes of administration. We have got IV, where the drug is given via the injected directly into the vein, and oral given by the mouth. It will be absorbed in the GIT. So let's start with the IV. When you inject a drug, right, in the vein, what will happen is that you can see that at the beginning when time is zero, the concentration of the drug is very high. Let's say, for example, that's 100% bioavailability. But then as time goes on, can you see that the concentration of the drug is reducing? Where is it going? It is undergoing metabolism, it's undergoing elimination, so it is reducing in concentration. But look at for someone that you have given orally the drug. Orally, just when you give the drug, firstly, you don't have the drug in the vein or in the systemic circulation. So at time zero, the concentration of the drug in the blood vessel is also zero. But as time goes on, what is happening is that the drug is now being absorbed into systemic circulation. That's why the concentration of the drug is increasing as time goes on. But as more time passes, what is happening is that now the drug is starting to be eliminated, starting to be removed from the body. That's why the concentration has started dropping. So you can determine the area under the curve for the oral route and the area under the curve for the IV route. So the bioavailability of a drug for any route that you've used is given by the area under the curve for that route divided by the area under the curve of the IV route, because IV route there is 100% bioavailability. So that's the formula for bioavailability given by the symbol F. Hope that's okay. So there are different factors that affect bioavailability. What are the factors that are going to make a drug to a large fraction of the drug to be found in systemic circulation or only a small fraction of the drug to be found in systemic circulation? So there are factors that are present in the drug that will make the affect bioavailability and the factors that are found in the patient that you are giving the drug. So factors in the drug, like the molecular weight. If a drug is much bigger, it means that obviously it might have some problems with being absorbed, right? It might have some difficulties in being absorbed. So that is going to affect bioavailability. And then drug formulation also affects bioavailability. So there is a standard or sustained release formulation. So what happens is this: for some drugs, the way you're going to be given is that you've been given this drug, and it's more like it is being kept by your body. When the concentration of the drug is reducing, the body is not going to be released again. Those are sustained release formulations. And then the drug solubility. For drugs that are not very soluble, you don't expect, okay, for drugs that cannot be able, yeah, which are not very soluble, you are not expecting them to dissolve in blood, because why? Blood contains water, right? So that affects bioavailability. And also drug interactions. Actually, there are some drug interactions are so bad that when you give drug A together with drug B, they can also they can even revoke your license, because it means that you could have killed the patient. There are some drugs that you never combine, because the effects that they give are so bad. Actually, some drugs, when you combine them, one drug will increase the removal of another drug from the body, the elimination, it will increase the elimination. Other drugs will reduce absorption of another drug. So all that affects bioavailability. The factors in the patient, these include first pass metabolism, which will reduce bioavailability. We'll talk about first pass metabolism. The chemical instability in gastric pH. So just pH also affects how much of the drug is absorbed. Intestinal motility. Let's say, for example, you take a drug and quickly you go to the toilet. It will be removed from the body, so it will not reach blood. And then lipid or water partition coefficient. Factors affecting absorption are the same for the factors that affect bioavailability. So these are the same ones that we discuss. So when let's start with fast pass metabolism, which is a factor in the patient that affects metabolism. What is a fast pass metabolism? Now, for here, I've put hepatic because mostly the metabolism is happening in the liver. So, fast pass hepatic metabolism. When a drug is absorbed across the GIT, it is going to enter the portal vein or portal circulation, and then it's going to go to the liver before it can go to the rest of the body. Okay, so you can see this is a blood vessel here. This is a blood vessel which will, when you have absorbed the drug, because there was the GIT side, you've absorbed the drug, and then it is going to go. If that drug is not taken, actually before then, you have gotten the drug, right? Let's say it's by the IV, by this is the GIT. If it is through the GIT, the drug will penetrate the GI wall, the epithelium, and then it will go to the liver. Or if it is goes into blood, it can be now eliminated by going in the feces and also maybe in urine and something like that. So when this drug goes to the liver, what happens is this: you are going to have some part of the drug being broken down, that will be metabolism, and then what remains, which is not broken down, is what is going to go to systemic circulation, that will be bioavailability. So bioavailability is after the drug has passed through the liver. Okay, and then the part that remains of the drug that is not broken down is what will be available to systemic circulation. If the drug is rapidly metabolized by the liver, the amount of unchanged drug that gains access to the systemic circulation is decreased. Those drugs that are rapidly broken down by the liver, you are going to have little of them remaining to reach systemic circulation, so the bioavailability reduces. And a lot of drugs, for example, propranolol, lidocaine, this is an anesthetic. Anesthesia, when you want to numb an area so that you can maybe perform a surgery. These drugs will undergo significant biotransformation during a single passage through the liver. So once they go to the liver just once, it means that nearly everything is broken down. So we're going to have little of it going to systemic circulation. So, what are the mechanisms of transport of drug across the biological membrane? How can a drug pass through the biological membrane? There is passive transfer. Passive doesn't use energy. You have got passive diffusion and filtration. You also have the carrier mediated transport. by facilitated diffusion or active transport. The drug can also be carried by endocytosis. So starting with passive diffusion involves the movement of a drug down a concentration gradient. That is why there is no energy being involved here. And it is not saturable. It means that whether you increase the amount of drug, because think of this, you have got a vehicle, right, which has got 20 seats. If you have got 50 people, if you have got 50 people, there is no advantage for let's say for example you are taking them to work, right? But at a given time you can only carry 20 people. So you increasing the number of people doesn't add advantage to the way the bus is going to function, because it is saturable, you can feel it. But passive diffusion, whether you increase the amount of drug, you'll not feel it to a point that the drug absorption stops, because there is no carrier that is carrying that drug. It is freely passing through the membrane down a concentrated gradient. So, which drugs are better absorbed by passive diffusion? You need small drugs which are lipid soluble. Remember, the cell membrane is lipid in nature because it has got a phospholipid, which is lipid. So, drugs that cross the cell membrane by this method are those drugs that are lipid in nature. And those drugs that are non-ionized, ionized drugs, these are polar drugs, they are charged. If you want drugs to pass through the lipid membrane, they should be uncharged, so that is unionized. They should also be small, because if it's too big it might not be able to cross the cell membrane. So these are the drugs that use this method. And passive diffusion is the most common and most important by which drugs cross the biological membrane. Another one is filtration, which is also the bulk transport solvent drug. So, filtration is the bulk flow of solvents and solid through a channel or pore in the membrane. You know how filtration happens, right? You have got a pore, but only those drugs that have got a small size can be able to penetrate. Those which have got a very big size will not be able to penetrate through those pores. That is filtration. So filtration is seen with small molecules that can pass through the pores. Some substances of greater molecular weight, for example proteins, can be filtered through intercellular channels. So we have got a cell. On between two cells you have got, those spaces. We learned this in physiology, that you have got the intracellular junctions. So just on there, the intercellular pores, some drugs, proteins can pass there. So concentration gradient is also going to affect the rate of filtration. The larger the concentration gradient, the larger the rate of filtration. Facilitated diffusion is another method by which you can absorb a drug into the cells or systemic circulation. And this method involves the transport of a molecule along its concentration gradient through the facilitation of a carrier protein. So because there is a carrier, it means that you are going to have saturation, because if that carrier is completely filled up, there is no other point by which you are able to carry that drug. But this method, facilitated diffusion, is different from active transport in that even when you are using a carrier, you don't require energy. Drugs and compounds that are too large and or too polar to diffuse through a lipid membrane are going to be transported by this method. Remember, the first one was the passive transport. So if drugs can't go by that method, if maybe they are large or they are polar, they have to go through channels, because at least channels can carry something that is charged, right? So the transport protein may become saturated, as we've said, and compounds may compete for binding on the carrier protein, and some compounds may inhibit these carriers. That's why when you give some drugs combinations, some drugs they'll tell you, when you take this drug, don't eat any food. Why? Because the food will also compete with absorption of that drug. Meaning that if you take that drug and then you eat food, it means that instead of absorbing the drug, you only be able to absorb the food, and then that drug will be eliminated. So you'll not feel better. Okay. Active transport, on the other hand, involves the active movement of a drug or ion across a membrane and can move against a concentration gradient. And it is a mode of transport for drugs that resemble actively transported endogenous substances, for example, sugars, amino acids, and nucleosides. So, in active transport, there is a carrier protein, and a drug can only be carried in one direction, and it requires energy. That's the difference with facilitated diffusion. Facilitated diffusion didn't require any energy, but active transport, though it has got a carrier also, but it requires energy. Okay. So competition for the binding and inhibition can also occur just like with the facilitated diffusion, because you are taking something and this channel can only carry something once at a time. Endocytosis is a process where small droplets are engulfed by the cell. There is this engulfment, and endocytosis can be by different methods. You have got phagocytosis, pinocytosis, and what we call receptor mediated endocytosis or clathrin mediated endocytosis. The reverse process for endocytosis, of course, that is exocytosis, is responsible for the secretion of substances. You can see phagocytosis, a solid has been taken into a phagosome, and then the phagosome can actually combine with a lysosome to form the phagolysosome to be able to break down what you have absorbed. This is the mechanism by which these phagocytic cells work. Pinocytosis is known as cell drinking. So you have got a substance that is taken in but is drinking. You can see the difference with the phagocytosis. Phagocytosis, you formed more like hands and then you engulfed something. But for pinocytosis, you are going to form an invagination, and then the substance is taken in and then there's closure on top. So that's the difference between the two. Okay. So there are different factors that influence the rate and extent of by which a drug is going to be absorbed. You have got these are the same factors that influence bioavailability. You have got the disintegration and dissolution of the drug, formulation of the drug, particle, let's say the particle size, lipid solubility, pH and ionization, area and vascularity of the absorption surface, GIT motility, presence of food, metabolism, the disease of the gut. So starting with the disintegration and the dissolution, drugs which are taken orally should break up into individual particles, that is to disintegrate for them to be absorbed, because you can't absorb something that is very big. And for drugs that are given subcutaneously, like they're going to be injected down the skin, or maybe intramuscularly, you inject them into the muscle. These drugs have to dissolve in the tissue before they can go into blood. And liquids are absorbed faster than solids. Okay, well, that's because mostly they are going to be able to dissolve faster. So delay in the breakdown and dissolving of a drug is going to result in the delay of absorption of that drug. The formulation also affects the rate of absorption. Pharmaceutical preparations are actually formulated to produce desired absorption. When a drug is just made, it is formulated in such a way that only the desired absorption should be, not only, but at least the desired absorption. Innate substances used with the drugs, for example, diurents like starch and lactose, the, these guys which are combined together with drugs, sometimes they also do interfere with the absorption, and that is you want to delay a bit, maybe with the absorption or the time period in which the absorption should happen, or just a problem with the drug, with the combination itself. So the way a drug has been formulated also affects how it's going to be absorbed. The size of the drug also affects its absorption. As we said, bigger ones are going to find more problem with absorption. Lipid solubility and ionization is a very important concept when it comes to absorption of a drug. Lipid soluble drugs are absorbed faster and better by dissolving in the phospholipid of the cell membrane. If you have got a drug that is ionized, that is not lipid, it is going to be problematic when it comes to be absorbed, because the membrane for absorption is actually lipid in nature. So because of this, ionized drugs are poorly absorbed, and ionized drugs are lipid soluble and therefore are going to be well absorbed. And most drugs are weak bases and weak acids, and they are going to exist in both ionized and non-ionized form. The degree of ionization of the drug will therefore depend on the pH of that drug. Strong acids and strong bases are highly ionized, so these guys cannot be absorbed well. So when you're talking about the ionization of something, you can use the pKa, the pH at which half of the drug is ionized and the other half is unionized. If the pH is less than the pKa, the protonated form predominates. Look at this so that you understand what we're talking about. Look at what's on top. Ha produces H plus A minus. This is a monoprotic acid. So this acid has disassociated. The pKa is the pH at which the Ha, the concentration of Ha, that is the acid, is equal to the concentration of A minus. Okay? So if pH is less than pKa, it means that what is more is, remember when you are finding pH is given by product over reactant. So if pH is less than pK, protonated form predominates Ha. Like this product, A minus, is more than the acid itself. So because of that, drugs will be absorbed in a medium having, okay, because of this, where when the pH is less than the pKa, since you have got more of the protonated forms, what does that mean? It means that that drug can't be well absorbed because of the protonated form. The protonated form is actually the ionized form. Same way with the base. So the main thing I want to take note of here is that weakly acidic drugs, which are unionized, they have got their absorption in the stomach. Weakly acidic drugs. Why is this? The stomach has got acid, right? The stomach has got acid, and like absorbs like. So acidic drugs are going to be absorbed in the stomach because it is acidic. Please take note that these are weakly acidic drugs, not the strong acidic drugs, because those have got poor absorption. While weakly basic drugs, they are going to be absorbed in the small intestines like the duodenum. Why? Because that area is alkaline, and these are weakly alkaline also. And they are unionized. Not the ionized, because the unionized guys fail to be absorbed because they can't pass through the cell membrane. Hope that makes sense. The area and vascularity of the absorbing surface is also very important. Let's say if you give a drug, the larger the surface area of the absorbing surface, the better the absorption. And at the same time, if you've given a drug, let's say for example, you've given subcutaneous under the skin, if that area doesn't have enough blood vessels, the drug will not be taken into blood, so absorption is bad. But an area that has got a lot of blood vessels, good vasculature, there's going to be good absorption. And most orally administered drugs are absorbed from the small intestines. GI motility is very important also. If gastric emptying time is faster, the passage of the drug to the intestine is quicker, and hence absorption is faster. GI motility, if it is faster, take note of that, right? When you get a drug and then motility is fast, like drugs can easily quickly move from the mouth fast, they reach the small intestines, absorption will also be faster. When intestinal motility is highly increased in diarrhea, absorption reduces. So gastric motility is supposed to be an advantage. Actually, the first point is gastric emptying, not motility, just gastric emptying. The rate at which drugs are moving from the stomach to the intestines. If it is increased, you're going to increase absorption because we said that most of the drugs are absorbed in the small intestines. But when motility increases, someone has diarrhea, the drug will be removed quickly. There is a quick elimination, and so you can't absorb that drug. Presence of food also delays gastric emptying, dilutes the drug, and also delays the absorption. So that's why some drugs will be told don't take it with food. Drugs may also form complexes with food constituency, and those complexes can be poorly absorbed. Diseases of the GIT like malabsorption and acrohydria results in reduced absorption. Acrohydria is where you've got low hydrochloric acid. So if you're not producing hydrochloric acid because some drugs that require this environment, it means that you can't absorb the drug. Metabolism in the gut. So some drugs can just be broken down in the gut. And the drugs that are broken down in the gut, therefore, should be given in high doses or give them by another method. Because if you give them in the gut and they're in the gut and they're broken down, there's no absorption. So those are the factors that affect absorption of a drug. Now, another concept you need to understand is the route of administration of a drug. When you give a drug, there are three main routes by which you can give a drug. So number one, the entero. Entero means relating to the GIT. You have got the oral method, sublingual, like you get a drug, you give it by mouth, someone drinks, or sublingual, you put a drug under the tongue, or enema. You see this one, I don't want to mention it. It's you getting the drug and then putting at the end of the GIT. You know the end of the GIT. If the beginning is the mouth, where is the end of the GIT? So you also have the parenteral method. Parenteral method can either be injection or inhalation. In injection, you can inject a drug in the vein IV or in the muscle intramuscularly or in the dermis intradermal or intraarterial or intraarticular on the joint or intrathecal. This is in the where, for example, when you're performing a lumbar puncture, injecting a drug there, and then subcutaneous, intramedullary, intraperitoneal. All these are parenteral methods. Inhalation, no, you want to give mostly those drugs that work on the respiratory system. For example, someone that is asthmatic. You can also give a tropical local application, a tropical or a local application. She's like, say someone has got a skin disease, just apply on that area where there is a problem. So the enteral routes, these are GI related. You have got the oral route, which is of course the most common route of drug absorption. And here the low pH of the gastric or of the stomach, or the low pH of about 1.4, the rate of gastric emptying, the pH changes will affect how fast you absorb the drug. Remember we said for drugs that are absorbed in the stomach, they need to be acidic, in the duodenum they need to be basic. And the drugs that you take by the oral method, they are going to, because when they're absorbed, they are going to be taken to the liver. So they will undergo what we call the first pass metabolism. They'll be broken down. Okay. Absorption also in small intestines. When the drug is absorbed in the small intestines, it will also go to the liver. So it still undergo first pass metabolism. Each one of these methods has got advantages and disadvantages. For example, the oral method is the most convenient to the patient. It is acceptable, it is painless, it is safe, it is also economical, it's cheap. And then for drugs that are intended to have effect on the GIT, the drug is placed at the site of action. Disadvantages can be maybe uh, slow when it comes to action. So you can't use them in emergency situations because they first have to be absorbed. For emergency situations, you can give maybe IV. And these are the disadvantages which you can read. You have got the rectal or the subsidiary route. This is where you get to administer the drug to via the rectum, and that is to produce local effect. For example, if someone has got problem with the GIT, especially the lower end of the GIT, like someone who has got the ulcerative colitis or hemorrhoids, you can give it there. Or to produce systemic effect. For example, if you give benzodiazepams like diazepam. These are drugs that you give even to people that have got depression, people that have been abusing alcohol. You want to help them in stopping and such. So these drugs can also go into systemic circulation when you give them via the rectal route. And this method, take note that it avoids first pass metabolism in the liver, so it is more advantageous than the oral method. And the rectum has got a lot of blood supply, but has got a limited surface area. You can read the advantages and disadvantages. The buccal and sublingual routes. So this is where you get the drug, you put it under the mucous membrane. And here there is a lot of blood supply, so the drug is going to be well absorbed. So you can see the sublingual is under the tongue, and then buccal you are putting like on the sides there. The parenteral routes, this is where you are injecting the drug or taking by inhalation. So intramuscular, this is where you're injecting the drug into the muscle. So can you see that when you're injecting the drug into the muscle, you inject it at 90 degrees. You do this in clinical skills. Intramuscular method, you inject at 90. Subcutaneous, you want a drug to reach just the subcutaneous tissue. You take it at 45. And then IV in the blood vessel, you want to take, they will tell you like somewhere between 15 to 45, but to get an average of 25. You also do this in clinical skills, how to inject a, a drug. You want it to go in the veins, and you want to go to the areas where I've got prominent veins. And then when you want a drug to just go under the skin, that's intradermal. Make sure that you take your needle a bit lower, like at 10 to 15 degrees, and then you'll be able to inject. You can see, for example, you can use these veins which are here. Advantage for this method is that there is 100% bioavailability, as we said earlier on the IV method, and it can be used in emergency situations. But it can have severe effects because the drug, maybe you have given more than enough, and you've given direct into blood. There is no way in which you are going to remove that drug, so it becomes a problem. And then some patients just don't like a needle, so that is inconvenient and is painful, and it is less safe, it is expensive. So all those are disadvantages. The intramuscular method here is also good. It's faster than oral method when it comes to absorption. And there are specific muscles that you want to be using. For example, you use the deltoid muscle. You can use also the vastus lateralis here. You can also use the abdominal muscles to be able to inject your drug. You can also use the gluteus maximus, specifically the upper outer quadrant, or the vastus lateralis. For the deltoid also, you actually put 3 or 2 fingers, finger breadths, and then from the deltoid process down, that's where we're going to be able to inject at 90 degrees. The advantages of the IM, it is reliable, suitable for some irritant drugs. It's also absorbed more rapidly and suitable for drugs that are not absorbed in the GIT. Depot preparation can be used with IM administration. These depots is where you give a drug and then it will be able to release itself after a period of time. Like you've given the drug, after a period of time, it can still be released because it is stored in the muscle. Okay, to be released. So it will be there for a long period of time working. So for the other methods, you can just read through there. And then the inhalation, or is also known as the pulmonary. This is specifically important for drugs that you want to be absorbed by the respiratory system. Topical method or route of administration, this is where you are giving a drug and it is absorbed. You are just applying it on an area. For example, if someone has got a skin infection or something. Transdermal is you have got a patch containing a day or week medication which is designed to be absorbed at a steady rate. So you can see this patch, maybe it's for 2 weeks, and then it will be absorbed at a steady rate, time by time, a bit like that, and not just at the same time it's all enters. That's the transdermal method. So that was about absorption of a drug.